Imagine walking into a hospital ward and the first thing you see is just sheer desperate chaos.
Oh, absolutely terrifying.
Right. But it's this organized chaos. You're looking at rows and rows of patients all completely paralyzed, and they're struggling to breathe.
Which is just a horrifying image.
It really is. And sitting next to every single bed is a medical student holding this rubber bag and manually squeezing air into a tube in the patient's throat.
Just by hand.
Literally by hand. Not for an hour or a day. We're talking around the clock in shifts for weeks on end.
It sounds like, a scene from some wartime triage tent, but that was actually Blegdam Hospital in Copenhagen back in 1952.
Yeah, that 1952 polio epidemic.
Exactly. And it's really the perfect backdrop for what we're doing today, representing this bustling 1950s Danish hospital ward where a lot of modern medicine was born.
Which brings us to our mission for you today. Welcome to the Deep Dive. We are going to unpack a stack of pathophysiology notes and clinical history on a topic that sounds, like a simple medical emergency.
But it's so much more than that.
It is. It's actually a fascinating window into how human biology works, and it's all about respiratory failure.
Right, because usually, we think of breathing as just one action, in and out.
Exactly.
Yeah.
But the sources reveal it's actually two completely separate jobs. And when gas exchange fails, it tells a very specific and sometimes wild story. So, okay, let's unpack this.
Let's do it. So to understand what respiratory failure actually is, we first have to look at when medicine realized it was something they could fight.
Because before 1952, it was basically just a terminal event.
Pretty much. You just watched and hoped, or you relied on negative pressure ventilation.
An iron lung.
Right, the famous iron lung. Those machines created a vacuum around the body to physically pull the chest open. But the problem was, Denmark only had one of those machines.
Oh, wow. Just one.
Just one.
Huh?
So when this polio epidemic hit and patients' breathing muscles became paralyzed, the mortality rate was sitting at this catastrophic 80 to 90%.
That's basically a death sentence.
Yeah. It was, until this anesthesiologist, Bjørn Ibsen, proposes a radical idea. He suggests using positive pressure ventilation, which was really only used in operating rooms at the time.
So instead of pulling the chest open from the outside, you're pushing air directly into the lungs from the inside.
Exactly. But they didn't have modern ventilators, so they recruited over 1,500 medical and dental students to manually squeeze those bags of air.
That is just wild to think about. 1,500 students?
Yeah, and it worked. Mortality dropped from that 80 to 90% range down to about 25%.
That is a massive drop.
If we connect this to the bigger picture, that specific event birthed the modern ICU. It changed respiratory failure from watch and hope to let's measure the gas exchange and actually intervene.
But that raises a big question. If we're measuring it, what are we actually looking at? The notes mention the clinical definition based on an arterial blood gas test.
The ABG, right.
The ABG. And the numbers are very specific. It says you are in hypoxemic failure when your PA2, your oxygen drops below 60 millimeters of mercury.
And then you have hypercapnic failure, which is when your carbon dioxide, the PaxQ2, climbs above 45 or 50.
Right, along with a pH dropping below 7.35, so your blood becomes acidic. But looking at these notes, I'm stuck on that oxygen number, 60.
It seems a bit random at first glance.
It really does.
Yeah.
The sources mention the steep part of the oxyhemoglobin dissociation curve, but they also say these cutoffs are somewhat arbitrary.
Well, arbitrary in a sense, yeah.
So how can a medical definition be a teaching simplification and not just like a fundamental law of nature? Why is 60 the magic tripwire?
So the best way to visualize that curve is to picture a cliff. When your oxygen is up in the 90s or 100s, your red blood cells are fully saturated.
They're holding all the oxygen they can.
Right. And as that pressure drops from, say, 100 down to 80, you're just walking along a gentle slope. Your saturation barely changes.
Because the body has that massive built-in buffer.
Exactly. But right around 60, you reach the edge of the cliff. The slope just goes vertical. If you drop from 60 to 50, your blood's ability to hold oxygen absolutely plummet.
You fall off the edge.
You fall off the edge. But to your point about it being a teaching simplification, you have to consider chronic lung patients.
Like someone with severe emphysema.
Yeah, someone with severe COPD. They might live with a carbon dioxide level in the 50s or 60s every single Tuesday.
Wait, really? Their normal baseline is someone else's failure?
Exactly. because their kidneys have had months or years to compensate by holding onto bicarbonate to neutralize the acid.
So failure is totally relative to a patient's normal baseline.
Right. You can't just treat the numbers on a chart. You have to treat the patient.
Okay, that makes sense. But since the numbers alone don't tell the whole story, we have to look at the actual mechanics, and this blew my mind.
The 2 jobs of breathing.
Yes. The reason this is so complex is because breathing is actually doing 2 completely separate jobs that can fail independently.
Type I and type 2 failure.
Right. Job 1 is oxygenation. That's type 1. It happens across the alveolar capillary membrane. It's about getting oxygen from the air into the blood.
Which clinicians call VQ matching.
Yeah. And then job 2 is ventilation type 2. That's the bulk movement of air in and out. It's a pump problem driven by the brainstem, the nerves, and the muscles.
And those 2 things can break down totally separately.
So I was trying to visualize this for the listener, and I came up with an analogy. Think of your lungs like a massive coastal shipping port.
Okay, I like where this is going.
So type I failure is when the cargo ships, which hold the oxygen, can't dock because the harbor is blocked or broken.
Right. The membrane is damaged.
Exactly. The cargo is out there, but it can't get in. Now, type 2 failure is when the cargo docks completely fine. The harbor is perfect.
But the trucks on land are broken down.
Yes. The trucks are the ventilation pump. They're broken, so they can't haul the carbon dioxide out of the city.
I love that analogy. It perfectly explains why carbon dioxide piles up in type 2. It's a pump problem.
The exhaust just sits there.
And this actually brings up a brilliant detective tool clinicians use called the AOAO gradient.
The alveolar arterial gradient.
Right. It measures the gap between the oxygen sitting in the alveoli and the oxygen that actually makes it onto the trucks in the arteries.
So what does it mean if that gap is really wide?
A widened gradient means the harbor itself is physically diseased. The intrinsic lung tissue is broken, so oxygen can't cross over.
But what if the gradient is normal?
If it's normal but oxygen is still low, it means the harbor is totally fine. The problem is outside the lung. It's a hypoventilation issue.
Meaning the brain or nerves aren't telling the pump to work.
Exactly. The truck dispatch center is offline.
To make this abstract pump versus membrane concept concrete for you listening, let's look at 3 very different real-world scenarios from the sources.
Real clinical cases make this so much clearer.
So the first one is severe ARDS from pneumonia. The sources describe this as pure type I failure. The host notes talk about the Berlin definition from 2012.
Right, they use the PO2 to FiO2 ratio.
Yeah, so if a patient is on 100% pure oxygen and their PO2 is only 80, their ratio is 80, that means severe ARDS.
And going back to your analogy, the room has plenty of oxygen, the ships are there, but the harbor is blocked.
Because of the fluid and protein in the alveoli.
Exactly. It creates what we call a shunt. The blood flows past the alveoli, but because of all that inflammatory muck, no oxygen can get in.
So you could blast them with all the oxygen in the world and it won't cross the membrane.
Right. That's pure type I.
Okay, so then scenario 2 is a classic COPD exacerbation. Advanced emphysema. This is classic type 2 failure.
Because emphysema physically destroys the architecture of the lung. It destroys the elasticity.
So it's essentially a broken pipe.
Mm-hmm.
The patients just can't exhale fast enough.
Right. They trap air, and because they can't exhale, the CO2 just climbs and climbs into the 60s or 70s.
And there's this wild detail in the notes here. It says patients will present with something called asterixis.
Yes, a hand-flapping tremor.
Wait, a hand-flapping tremor? From lung disease? That's crazy.
It is, but it happens because of CO2 narcosis. When carbon dioxide gets that high, it crosses into the brain and acts like a sedative.
So it's literally poisoning their nervous system.
Exactly. The brain loses motor control, hence the flapping tremor. It's not just breathlessness, it's a systemic failure.
Wow. Okay, the third scenario is the cleanest teaching case for type 2 failure, an opioid overdose.
This is a perfect example of the pump failing while the lung is completely healthy.
Right, the lung tissue itself is pristine, but opioids suppress the brainstem. The drive to breathe is just broken.
The dispatch center is shut down, CO2 builds up instantly.
And this is exactly why naloxone or Narcan works, right?
Yes. It doesn't treat the lung tissue at all. It rushes into the brain and knocks the opioids off the receptors.
So it restores the brain's drive to breathe. The pump restarts. But let me clarify a common misconception here. So respiratory failure doesn't automatically mean your lungs are diseased.
Absolutely not. The pump can break at the brainstem, like with opioids, or the spinal cord, like in ALS.
Or even the muscles, like with Guillain-Barré syndrome.
Exactly. The lungs can be totally pristine in all those cases, but, and this is key, they aren't mutually exclusive.
What do you mean?
If you start with a pure type I problem, like severe pneumonia, the patient is working so hard to breathe that they exhaust their muscles.
So a type I failure can essentially force the body into a type 2 failure because the pump just gets too tired.
Precisely, it evolves into combined type I and type 2 failure.
That's just a brutal cascade. And because these mechanics are so delicate, the way doctors historically tried to fix them was sometimes completely backward.
Oh, absolutely. There were massive debates in critical care.
The sources outline some famous medical reversals, like the hypoxic drive myth. Here's where it gets really interesting.
I love talking about this one.
So for decades, doctors were terrified to give COPD patients oxygen because they thought it would stop their drive to breathe.
Right. The theory was that because they lived with high CO2, their brain only cared about low oxygen to trigger a breath.
But the sources reveal this is mostly a myth, or at least the reasoning was totally wrong.
The real danger isn't that they forget to breathe. It's actually the Haldane effect.
Which is when oxygenated hemoglobin releases CO2 back into the blood, right?
Exactly. And on top of that, you have worsening VQ mismatch.
So flooding the damaged lungs with pure oxygen actually messes up how the blood vessels compensate.
Right. The lesson survived. You still have to titrate oxygen carefully for COPD patients, aiming for like 88 to 92%.
The textbook reasoning they taught for half a century was just flat out wrong.
Science correcting itself.
And that leads to another huge shift: permissive hypercapnia. The notes mention this landmark ARDS-NET trial from the year 2000.
That trial completely changed the ICU.
Because doctors used to push 12 milliliters per kilogram of air into a patient just to fix the numbers on the monitor.
Huge breaths, but they realized those massive volumes were actually injuring the lungs.
They were shredding the tissue. So the trial dropped the volume to 6 milliliters per kilogram, and mortality dropped from 40% to 31%.
A massive improvement in survival.
But wait, so doctors realized the ventilator was overdistending the lung, so they just decided to deliberately tolerate bad CO2 numbers.
What's fascinating here is that, yes, they did. It was a striking reversal of the medical instinct.
The instinct to just fix the numbers on the screen.
Exactly. They realized that letting the blood become a bit acidic, permissive hypercapnia was far safer than physically tearing the lung apart with pressure.
That requires so much restraint, just looking at a bad blood gas and doing nothing.
And it shows how the field is always evolving. I mean, we're still debating oxygen targets today.
Right, the Noakes mentioned the ICU ROX and OLE CO2 trials. They're still arguing over liberal versus conservative oxygen targets.
More oxygen is safer versus less oxygen is safer. It's still an active, unsettled debate.
It's wild that something as basic as oxygen is still so contested. But it makes sense when you see how complex the system is.
And how easily it can hide what's really going wrong.
Which perfectly transitions to the final section of our notes.
Yeah.
We've established that the numbers don't always mean what we think they mean. But what happens when the bedside tools we use to get those numbers are fundamentally flawed or misleading?
This is where we get into the invisible failures.
Yeah, let's talk about COVID-19 and silent hypoxia. This was a startling phenomenon back in 2020.
I remember it vividly. It broke all the rules.
Patients were coming in with pulse ox readings in the 70s and 80s, but they were alert, talking, and not gasping for air at all.
It completely violated the golden rule that hypoxemia causes dyspnea, that feeling of breathlessness.
So why did they feel like they were suffocating?
Because early on with COVID, the lung compliance was preserved.
Meaning the lungs were still stretchy.
Exactly. The membrane was failing to exchange gas, but the physical work of breathing didn't spike.
Because the lungs weren't stiff and heavy yet.
Right, so the mechanical strain wasn't there to warn the brain. The gas exchange failure was completely hidden from the patient's subjective senses.
That is genuinely terrifying. But speaking of hidden failures, the host notes highlight a 2020 study by Joding in the New England Journal of Medicine about pulse oximetry bias.
This raises an important question about the tools we trust every day.
Right, because the study showed that pulse oximeters were 3 times more likely to miss occult hypoxemia in Black patients compared to white patients.
Which is a huge systemic issue.
Because the light absorption tech interacts differently with skin pigmentation. The melanin throws off the reading.
And this historic bedside tool has a genuinely surprising limitation that went largely unquestioned for decades.
It's directly reshaping FDA guidance right now. It just proves that gas exchange failure can be entirely invisible.
Which is exactly why objective arterial blood gases remain the ground truth. You have to look at the blood itself.
You really do. So if we step back for you listening, to summarize, this whole deep dive respiratory failure isn't just one big breakdown.
It's an entire spectrum.
Right, it's a spectrum of membrane and pump problems, influenced by everything from 1950s polio wards to modern pulse oximeter biases.
And you have to remember, oxygen alone only cures a type I problem.
Right, because if the trucks are broken, you need mechanical support to fix the type 2 pump.
You can't just give them more cargo.
Exactly. So before we wrap up, what's a final thought we can leave the listener with today?
Well, going back to the COVID-19 silent hypoxia phenomenon, consider the profound disconnect between the brain and the blood.
It's so unsettling.
It is. Our bodies evolved these complex alarm systems to make us feel breathless and panicked when we are in danger to save our lives.
Right.
Yet a virus can silently dismantle our gas exchange while the brain sits completely unaware, chatting away. It makes you wonder what other physiological emergencies our subjective senses are entirely blind to.
Oh man, that is a wild thought to chew on.
It really keeps you humble about human biology.
It really does. Well, thank you all for joining us on this deep dive. Keep questioning the tools you used and the world around you, and we'll catch you next time.